To kick things off, please welcome Shantanu Agrawal.
All right, thank you so much. So as we get situated, I'm just going to do a little bit of a brief introduction to the panel, and then we'll get started. So I am the CEO of the National Quality Forum based in DC. And I will say, I already know the panel is very high functioning and excellent because due to a lot of delays, I got here 10 minutes ago and just got to meet them, and they were already having a great conversation. So I feel like I'm just going to be here to get things started, and then I'm sure they'll take it off. So we will go around, and I'm going to ask each of the panelists to introduce themselves and just sort of talk for a few minutes about what personalized medicine means from your standpoint. And then the format of this is I'll lead the discussion for maybe 10 or so minutes, and then we really do want it to be very interactive. So we'll open up the mics for the floor and encourage you all to get involved from there. So maybe we start at the end with David to go first.
I just want to start by thanking the Millennium Alliance for the conference and the invite. My name is Dave Meyer. I'm with Scan Health Plan. We're a medium-sized health plan based in Long Beach, California, about 190,000 lives. I own revenue, compliance, stars, data submissions, audits, things like that. I already kind of shared how often we're getting audited in the last session, so in this one I'll share something slightly different about myself, which is one of my undergrad degrees was English literature, and I did graduate work in epidemiology and biostatistics, which makes me a motivational statistician. So anyway, and then and as far as this topic, just the briefest, initial comment. I mean, I am so jazzed about it. I spend all day long block and tackle on revenue and ensuring compliance and accuracy around revenue. I think the promise of personalized, individualized healthcare, leveraging technology in a meaningful way, transforming the way we on the plan side ask physicians to execute population-based healthcare for us, right? Which is brain damage right now. I mean, doctors absolutely hate the lists that we're sending them and the forms and all the pop-ups and all these things that on the plan side we think are brilliant. They hate. And you can imagine this scenario in the future where individualized care, where a member is driving, a patient is driving the interaction with healthcare, changes the conversation. This is no longer a plan now pushing what I want you as a provider to do. This is a conversation between a provider and a member based on a member's choice of how they want to be interacted with. And I just think that's intrinsically so exciting. So jazzed to be here and looking forward to this conversation.
That's great. Already touched on a lot of great topics. Karen.
Hi, I am Karen Hill. I am the SVP and CMO of Community Health Choice in Houston, Texas. We are a county-owned, non-for-profit organization that does Medicaid, CHIP, and Marketplace, going to expand into the aged, blind, and disabled and LTSS population, hopefully in 2020. As I look at technology, we are a managed care organization, so that has shifted from back when I started in medical school where everything was fee-for-service and doctors managed care. Insurance companies are taking a larger role and have to take a larger role in the outcomes for our members. But I think it should be a partnership, and I'm interested in discussing, since there's a lot of technology out there, I think we're at the cusp of a new revolution. And in implementing it and sharing it with the physicians as regards to taking care of members and achieving our quality outcomes.
Great, thank you.
Hi, Dan Meltzer. I'm a similar title as my colleague here, as Senior Vice President, Chief Medical Officer at Blue Cross of Idaho, 6 months in. I'm an emergency physician, still practicing. I practiced clinically at Kaiser Permanente for about 17 years, where I was prior to coming to Blue Cross of Idaho. Blue Cross of Idaho serves about 600,000 members, all lines of business. We're the largest commercial payer in the state of Idaho, but the state of Idaho is about half the size of San Diego from where I came. So, which is actually one of the reasons I left, which is it's sort of a small enough, big enough dynamic where you can get stuff done, but still have economies of scale and scope to do it as a $3 billion company. As far as personalized medicine goes, I can't tell if it's a redundant statement or an oxymoron, and what I mean by that is I hope it's redundant in that my hope as a clinician is that all medicine ultimately is personalized. It's the relationship between the clinician and the individual patient. P.S. We're all patients. We all have individual needs. The oxymoron part of it is here we are as payers, most of us, where we're really in the arbitrage business. We're arbitraging risk. We're arbitraging price. We're managing populations. We have this notion of population health. So how can we reconcile the notion, and I think the ideal that all medicine and the kind of the motor end plate of healthcare really is that between a clinician or a physician and a patient, and ultimately is personal to what matters most to us, and managing populations. How we do that, I think we'll get into, but one of the themes that came out of my previous conversations was integration. So integration between clinicians, integration between patients, integration between payers, integration between technology and services. So how we integrate that ultimately to serve patients, again, P.S. we're all patients, is really, I think, what we mean by personalized care.
That's great. Thank you. And Michele.
Good afternoon. So you guys took all the good points. So by the time I get here, good afternoon, everyone. I'm Michele Koppenhaver. I'm the Regional Vice President of Value-Based Collaborations in the Southeast region for Aetna. So my team is a field team. We're externally facing, and we are meeting on a regular basis with our accountable care organization partners, which could be health system, it could be a large physician group, could be a clinically integrated network. And what we do is we launch ACO products as well as ACO attribution models for both collaboration and Medicare Advantage. We work on other types of value-based arrangement like bundled payments and other things, including telehealth and et cetera, all the new models that are coming along today. So really enjoy my work with providers. I learn a lot from them every day. And what's really great by meeting with so many of these providers is we can share best practices because, we can't kid anyone, we're all still learning, right? This has been around for a while, but it's evolving very quickly. And we have to stay in the know about all the new technology and all the new ways to look at the basics of clinical care, if you could say. And so I agree with David. When I think about personalized medicine, I think, well, how can it not be personalized, right? We're all human beings. We all are very unique. If medicine were easy, it wouldn't take physicians so long to go to school, right? So when we think about clinical care and clinical care models, I think what we have to do, though, is how can we put this in the context of all the new technology that we have today? How can we take advantage of all these new innovative models and programs that we're developing to enhance the clinical care and care management? So when we think about someone's health, 10%, according to the Kaiser Foundation, 10% of our health care is impacted by the clinical care we receive. So we've got to do more than just think about the clinical care, right? We've got to think about clinical care in the context of personalized medicine. And when we think about personalized medicine, it's much more than what a patient brings and is sitting in front of you with when they're in the clinic. It's what they face when they go home. It's what they're facing with their families. It's what they're facing in their jobs. Those are all the components that have to be considered when we think personalized.
That's fantastic. So I'm going to start with you first. That way we can move the other way, and you can get some of the better stuff right out the gate. So I wanted to know, in each of your positions, what is something that you feel you can do that, or rather, what's a barrier that you can lower to actually getting personalized medicine adopted more quickly, to catalyze it somehow, and then how do you think it's going to change your job?
Well, I don't know about you guys, but my job is changing every day or every hour maybe. I think the biggest way to impact all of this is to really look at the social determinants of health, to bring healthcare local, to bring it in the communities. And, we can't kid ourselves, none of us, I don't care if we're a provider, payer, government, whoever, none of us can do this alone, okay? It's going to require a lot of people. A third of the healthcare dollar is being wasted. How can one entity or one type of entity do that, okay? So it's going to take all of us working together in the local community, figuring out what's happening in a person's zip code that is a barrier. Why is it the patient won't comply with the medications? Why is it they won't come to their appointments? Why is it, that they're having to choose between asthma medication medication for their child versus breakfast, okay? Until we solve for those kinds of things that are impacting people on an everyday basis, you know, we're not going to be able to move the needle and improve healthcare costs and member satisfaction or patient satisfaction. So I see those as the big things we've got to start doing. We've got to get into the community. We've got to make it real. We've got to be in patients' homes. We have to figure out why healthcare is not moving for a large segment of the population.
That's great. Dan, do you want to take that question up?
Yeah, you want to ask it again real quick?
Sure. So what's a barrier that you think needs to be knocked down to really realize the potential of personalized medicine? And then how does it affect your job, do you think? Or
Yeah,
how does
I think
it change your function?
I think it depends on, which we still haven't really landed on, which is a definition of what we mean by personalized medicine. In fact, I'd be curious maybe how you define it or some of the members of our audience. But that being said, I'm biased in my role as a physician, which I still feel like that physician piece is really the key to delivering on what it is we hope as patients will be actualized, that is in the form of health and healthcare. So I think one of the things that I can do is be a facilitator, an empower, an enabler, if you will, of physicians to allow them to do their job, not necessarily do more stuff with time they don't have, but allow them to deliver personalized care as the patient defines it, which I think really is care that's directed at me, that focuses on my needs, be they social, medical, psychological, behavioral, or otherwise. And I think we can do that in a variety of ways. I think we can do that through the contracts that we arrange. I think we can do that through leveraging technology and providing technological solutions to and for them. And much of the conversation that ensued previously was around integrating technology and how do we have more of a holistic view of technology, that it's not so disparate. I think we can do that in the form of services, be they MSO type services for independent physicians, for example. Whatever we can do really, you know, as facilitators, because at the end of the day, I think, again, patients, PS, we're all patients, we want our payers just to allow us to do what we want, which is to get access to the doctors that we want to see when we want to see them and hope that the doctors are good. So whatever we can do to facilitate that, again, particularly for physicians, I see as something that we can do to tap into personalized care.
That's great. Karen, your answer.
And I guess I'm going to leverage from both of you. I agree with both of you, obviously. But I think, taking from what both of you have said, I agree that we need to leverage what each individual needs personally. And I think our medical system focuses in silos, where your payment model is only going to allow you to pay for things medical. When you know that asthma patient who has a cat and carpet needs to have the carpet ripped up or a leaky roof, you know, those are the social determinants of health. I think we're going to have to leverage partners in payment, our community resources, using the physician to identify some of those needs in order to get down to all of the specifics that are going to make healthcare better. I think our healthcare system has been too siloed in looking at just medical problems and not looking at the bigger issues that contribute to that.
David.
Just out of a desire to say something different to differentiate myself. I'm going to put a stake in the ground on the plan as the barrier, because I just think it's an intrinsically interesting thing to talk through. Certainly from a medical group perspective, from a large medical group, and I spent half of my career on the medical group side. From large, sophisticated medical groups' perspective, plans, and particularly if you contract with 8, 10, 12 of them in your market, plans with their various good ideas of the same report that you get redundantly for as many contracts as you have, are an intrinsic barrier. And so a health plan coming into a market with this grand idea, and I liked your definition, by the way, Daniel, of how you defined personalized care. So let's just leveraging that. You know, a plan coming into a market where there's a lot of penetration of other payers, I think is an intrinsic barrier to adoption. And so I think I would say, certainly in my market in California, probably I know some folks are from other parts of the country. Florida is a great example where there's high penetration of large physician groups. Other parts of the country that, you know, very, very different, right? But I would certainly say in California, making sure that this is palatable and acceptable and ownable by large physician groups as opposed to the health plan, and we just sort of go along for the ride, is going to be critical. I think in other parts of the country, physicians are probably not in the position to take the reins and drive some of the changes that we're talking about. It would have to be from the payer side. But in California, absolutely. I think plans having the wisdom and the let's say the humility to tee this thing up and then step back and allow others to run with it, I think is going to be important.
That's great. So I'm just going to open it up, and whoever wants to jump in. But I think riffing on a few of your comments, personalized medicine is often taken to mean a technology solution. And often I think that can be an expensive technology solution. So how does personalized medicine interact with the cost of care and with the quality of care? And what will that mean, again, from a payer perspective?
I can start.
Jumping in.
Okay. So I think personalized medicine does include technology, and I think that I'm seeing it from payers like ourselves at Aetna and also other payers. I'm also seeing it from the provider space a lot. So I think, though, to me, personalized medicine technology is one piece, but it's also the basics. It's one-on-one, sitting down with the patient and listening, putting the computer over here, and one-on-one listening, the basics, going to their homes. It's almost like we've seen this big shift of away to the home, but yet at the very same time, we're suggesting telehealth. We're suggesting text messages. We're suggesting portals. We're suggesting, an app where you can, see if your CHF or what your glucose level is. I mean, I think it's all these things, and I also think that what really aggravates me is people go, well, should we do population health or should we do personalized medicine? And I think it's an and, it's not an or, because to me, population health is understanding who your patients are. It's the identification, stratification of those patients, understanding the hierarchy, understanding the top 5% that drive 50% of the cost, so that you can manage those patients chronically and then go in and do the personalized approach, because this diabetic is not like this diabetic, this hypertensive is not like this hypertensive. So it's within the context of understanding who your patients are, then going into personalized, then applying, like Daniel said, listen to the patient. What works for this patient? How can I engage this patient? Is it technology? Absolutely. So we're going to text, we're going to do telehealth, we're going to do an app, we're going to have them weigh every morning and call in. But for this one, it's going to the home once a week. It's having a conversation over a cup of tea. It's talking to the adult daughter who's the caregiver. So I think personalized is very literal, and it does include any and all of those things. And that's the point, is it is personalized, and it's using all these things that we have access to meet the needs of given patients within this hierarchy we've identified through population health.
So what I'm hearing is some patients get a high technology approach that might actually be more expensive, but for others it's sort of high intensity, high impact, high touch, but not necessarily high technology, and that actually can level out over a population. What do you all think? Is that sounding right?
Yeah, I think you've got to basically fit it to the patient. I mean, your millennials are going to be all into Instagram and Snapchat. I know that's what my kids are into. My mother-in-law, 85, not so much. So they're all using the healthcare system, so you've got to meet them where they are.
It's not true. I follow her on Twitter. She's really prolific. Really prolific. Dan, you have mentioned a couple of times the physician perspective in this, very important. I'm an ER doc as well. I'm wondering, are all physicians ready to do this? Or if not, what can you do? What can we all do to get them ready?
What's this?
Actually engage in personalized medicine. So I think about working the ER shift, and so much of that is the opposite of personalized. And I think that's probably true of many clinical environments today. So maybe it's physicians writ large, or even are there certain clinical areas that will be far ready to go at this earlier, to actually engage in a much more personalized approach, whereas others might be more lagging. I just wonder what your perspective on that is.
Again, it depends on how granular you want to get. I still think at the end of the day, medicine is a humanistic profession. it's a noble profession. Ideally, it involves, you know, a modicum of science, but it's about taking care of people. I don't see how that can be anything other than personal. I think that the best of medicine is still there to have. You know, typically when I'm at the bedside of a patient, there's not a regulator on my back or a CMS auditor next to me. So I think what we want to do is do everything we can to get back to what the best of medicine offers, which is that between a physician and a patient. So I don't see it as the current state as sort of anathema to personalized medicine. I think there's a lot of technology that's actually making it worse. You know, and certainly statistics on burnout, you know, vet that out in the form of EMRs in particular. So the key is the right technology done by the right people, scribes, for example, that allow the right process to ensue that manifest as a personalized care. And I think we also have to differentiate personalized care from precision medicine, because I think it's feeling a little confusing to me. You know, precision medicine, we understand the genomics, we understand the science behind that. Personalized care is still a lot more amorphous. And the other piece with technology I think we have to understand and differentiate is technology versus services and how they're going to apply to healthcare, health and healthcare. And someone mentioned earlier this notion of the differentiation between healthcare and health, that healthcare is really moving more towards health in the form of social determinants in particular. That really, we understand that the unit cost of service is higher than technology in most cases, and we talked about that a little bit earlier. But at the end of the day, healthcare is a service industry. Ideally, the technology enables the service, and that service can be communication, it can be biometric monitoring, it can be a variety of things. But to your point, I hope that the technology really manifests and allows for the service to ensue, which ultimately I can't help but think is personalized.
That's great. So I think everybody has at some point already mentioned the social determinants of health, social risk factors. So I think, Michele, you cited data that I think is true and cited a lot. So, you know, roughly 10% of health outcomes really are accounted for by sort of traditional clinical risk, clinical services. Probably 80% or so are the social risks, and then obviously you've got biological, genetic risk as well. So if we, and what I really like about the framing is you're threading the needle between population health and social determinants, right? That is a way to both personalize population health. I think really smart, and I credit the panel for really coming up with that. So I think the question is then, if we have to go after the social determinants, what do we need to do? What do you think about to actually move the system to taking that into account? Because certainly today, we do that very little. And is it a matter of just payment models, or are there other potentiators that make that possible?
I can chime in only because it's fresh on my mind. I don't mean to monopolize the conversation, so David and others, please chime in. And I can just speak from the Blue perspective, because this is being addressed at a national level, so some of my colleagues may have some insight into this. But one of the things that the Blues are looking at as payers is partnering with other companies, i.e. Lyft for transportation, or Albertsons for food, Albertsons in the form of even its pharmacy benefits as well. So how can we work holistically as communities and as companies? So if transportation is an issue, how can a Blue, for example, work with a company like Lyft to get Mrs. Jones from her home to her doctor, or conversely, get someone from their office to Mrs. Jones? How can we get people that live in food deserts, which we know are not infrequent in the United States, to access to the right nutrition? And by the way, when they have access to it, do they have someone there that can educate them on it? So having dietitians or nutritional experts actually in the grocery stores educating people. When they go to pick up their medication, how can we have a pharmacist in the store and empower pharmacists to operate at the top of their license, not just dispense medications, and really have conversations with patients? So it's, again, back to this notion of integrated, as payers working not only with clinicians, which I've talked about a lot, but other people in industry to solve the same problem, so it's a win-win. So we're providing financial incentive to the Albertsons of the world, or maybe a marketing advantage, or providing financial incentive to the Lyfts of the world, and yet we're serving our members in a way that's a lot more expensive, and I say this lovingly, than an ER visit.
Mm-hmm. Yeah, absolutely. Karen, David, anything you want to add to that?
Maybe just kind of going back to the previous question you asked around quality, and I just want to kind of hang there on quality. There's so many different ways that we process and think about quality in healthcare right now that are sort of at odds. You think about, within the Part D measure set for CMS stars, those quality indicators are not measured by patients, having better outcomes. It's not measured by patients actually taking the medication. Those quality measures are measures of commerce. Did the patient purchase pills this month? And so one of the places that, and this gets back to why I'm so excited about what I think of, at least in my head, as of personalized healthcare, because I would really like to get back to that. I'd like to get back to a doctor, as you were saying, a doctor and a patient interacting, and an E&M that manifests itself in some impact on that patient's life. And I think right now there is a kind of a soulless schizophrenia in Medicare Advantage around how we handle and how we think about quality. And it comes back to the point you were making before about needing population-based health care, which I absolutely agree we do, pragmatically, right? You must have these measures in place that go after the widgets and the units, because that's how quality is measured, right? But it would be so satisfying to be, in our lifetimes, part of a transition back to a relationship between a doctor and a patient. And even if that relationship is through telemedicine or through text or through email, all of which, I think we've got to be ready to embrace. But I would just love to get back to the E&M.
So you said the words quality measurement. I'm from NQF. I'm going to take the bait. I got to. Absolutely agree. And I think the phrasing of sort of thinking about it as a commerce transaction almost sort of captures some of the shortcomings right now. So how do we change that? I mean, so part of personalized medicine, I certainly think about this a lot, is if we're going to allow for a greater variety of different clinical interactions to happen, if we're going to get out into the community and start addressing social determinants in a meaningful way, sort of tracking of that, understanding what the outcomes are, will be really challenging. So how do we change either measurement or the approach to measurement to actually capture those outcomes?
Yeah, and just to follow, thank you for the question. And obviously, I framed it the way I did because it's slightly salacious. I
like
that.
Provocation is good for a panel.
But I mean, think about one of my former territories, Puerto Rico. So one of my former companies, we had operations in Puerto Rico. In Puerto Rico, a lot of our members just couldn't afford drugs every month, right? It was critical for them if they needed 10 milligrams of something to get a script for 20 and break the pill. But these people are now intrinsically non-adherent, right? From an NCQA style measurement set. So in terms of what do we need? I think we need to begin to play with different ways of assessing outcome. And I think we should be open to that conversation and allow that to sort of evolve naturally. So I think a serious conversation around what other measures of quality should we have in addition to the current set around widgets and let's say satisfaction, which is not really whether we do something right or wrong, right? It's whether the patient feels that we do something right or wrong, which is now a measure not so much of your network, but of your members. So one of the things for those of you that have a lot of many lives, they're more satisfied than your Medicare Advantage lives, right? But why is that? They have the exact same network, they have the exact same doctors. Why are they happier? They are at SCAN. Why are they happier? Well, there's something intrinsically different about those members. They have a different experience in life with interacting with people that have power over them. And when they get something of value, they're very, very grateful for it. And that's an intrinsic difference, not about the healthcare, right, but about the member. So I think it would just be lovely to come up with ways to talk about populations that are intrinsically meaningful, as opposed to the big broad brush that we have right now. And I think, so to me, yes, this is a technological focused conversation around sort of the emergence of personalized care. But to me, it's this wider sweeping conversation about how can we pull away from some of the clunky measures of quality and outcome that we have right now and sort of re-embrace what I was saying before, the E&M.
Yeah, very cool. Anybody want to add to that?
in a more simplistic form, I think what I'm hearing and what I feel is like we need to go back a little bit in how we used to perform medicine. The old mom and pop, one doc took care of the whole family, and yes, you did communicate with your pharmacist, but we also need to integrate some of the technological advantages we have now, because I think we have become so disjointed with, trying to meet measures that don't really measure, is what he's talking about. If we go back to taking care of the patient, making sure, that their needs are met and that they're healthy and happy, kind of like Andy Griffith's show, for lack of a better model, but integrating telehealth and texting and Snapchat for those who are able. In a grand scheme of things, that's kind of what we need to do.
Yeah, I mean, I think the question, if I understand it, is really around optimizing outcome measures. And the first thing is there's just too many. I mean, I think no one needs to be measured more on anything at this point. So who's driving home? That is to say, are we measuring because someone told us to measure? And if we do correctly, we get a star, or we get a number, or we get $1. So that's part of it. Number one, too many. Number two, who's telling us to measure, and why isn't it reverse engineered around who are we actually serving, which I think is the point that David mentioned. And the other thing is, what is the outcome intended to actually do? Is it perception, or is it actual quality? In fact, they probably both matter, or is it cost? So I don't have an answer yet to how to optimize it, otherwise I probably wouldn't be sitting here. But the other piece is really, that I know we struggle with, at least at BCI, is against whom and against what are we measuring? Benchmarks. There's just a lack of transparency, even amongst the blues, regarding where we should be. So oftentimes I feel like we're just the cream of the crap. We're not, I mean, if we're at a percentile of what? I don't even know what that actually means. So less measures, the right measures that serve the right people, and benchmarks that actually make sense and are transparent.
All right, so you reach it for the mic, go ahead.
Yeah, so I can add a little bit. So I would suggest that any kind of measurement would require patience and flexibility, because I think we do need some short-term measures. And then I would recommend or suggest that we need some midterm and then long-term. So by patience, I mean, I mean even generational, right? I mean, we can't just figure out if something's working from one number. So, like a diet, HbA1c, that's just a number, that it's an indicator, but it's not the whole person. So I think that we have to have some of that to get started, and we've got to move from processy to outcomes. But then I think we have to broaden our view and look at it more globally and think about the person again. Personalized medicine this patient is not just an HbA1c result. How is this person, and all people that are kind of in this category, I guess, of chronic disease, generationally, how is this looking? So I think that you have short, mid, long-term goals, but then you're flexible enough to revisit those on a regular basis, because technology and other innovations are going to change how we want to measure over time. But I would just I think that we have to have some of that just to get started, and to have something to kind of launch from. But then we have to have the patience to look at things longitudinally. Then people go, oh, well, what about money? What about funding? What about ROI? If I can't measure it in 6 months that this was worth the money, then we're not going to do it. But I think sometimes there has to be a balance between those things.
So I'm going to ask one more question, but I'm giving you all advance notice that right after that I'm going to open it up to you. So get your burning question, your burning comment ready to go, and we do invite both. So your question can end with a period, that's okay. So last one for me, we were having a discussion right before this that I think would be good for the entire audience to kind of get privy to, which is all of these changes that we have already discussed, transitioning more to taking on social determinants, new approaches to technology, new ways of interacting with the patient, new approaches to quality measurement or just outcomes measurement. Who's responsible for all this? Is this a payer responsibility or primary accountability to really get us towards this end stage of personalized medicine, or is it somebody else's? Is it a combination? Who wants to jump in on that?
I'll start.
All right.
So first of all, yes. All the above. And secondly, if you've been reading any healthcare news at all in the last 6 months, the lines are blurring. Who is a provider anyway? Who is a payer anyway? Payers are buying providers. Providers are buying payers. Post-acute care is joining, payers. Pharmaceutical company is becoming this and that. So first of all, it's not so black and white anymore as to who is whom, right? So, we can't just say who is responsible. It's all of us. And then with each entity, I love the talk about multidisciplinary care teams. I love seeing pharmacists making rounds with physicians in the hospital. How cool is that? For those of you who were in medicine 20 years ago, the pharmacist used to be in the corner pushing buttons to dispense meds for the med nurse. Now they're hugely valuable team members. They're making rounds. They're meeting with the patients. We've got social workers right there. So I just think that we're all responsible, and we all have a part in what this is. And I know we don't have a lot of time.
That's all right. Anybody else want to jump in? Are we waiting on any level for the public sector to act first, or more definitively? So it might be everybody has a role, but are we asking or expecting the public sector to take the lead?
I don't know that we're waiting, but I would hope that they would jump in. It's their health, and if you want to be personal about it, they've got to take an ownership of what's going on with their lives and their health.
They already are. I think, if you look at where the wealth of the amount of capital, sort of as we define wealth, the amount of intellectual capital that's being devoted to healthcare now, it's unprecedented. 5, 10, 15, 20 years ago, it was in sort of true technology as we envision it, in computers and in software and in hardware. And then it was in solving other problems, be they aviation, be they travel, be they economics, be they financial. Now I think what we're seeing is all of that economic and intellectual capital really be devoted to healthcare. And you need to look no further than any publication. And you see people that were at Google or were at eBay or were at PayPal are now spending their time, their money, and their resources in and on healthcare. Or you see those exact companies, Amazon's a perfect one that we mentioned, really devoted to healthcare. The 18% cannot become 20%, it just can't. So I think this already is a public problem. Health is a public problem. Now the public is actually looking to solve it.
Great.
Yeah, I would just say, in terms of the split or who should own, I think I kind of blushed at this earlier, that, I think it depends on what part of the country you're in. Certainly, we would all, I think, agree it's got to be a partnership between payers and providers, but that split in that partnership, right? Who has 80% and who has 20%, I think changes depending what part of the country you're in. And certainly in California, I think if we try to create a model where the payers were going to drive this and the medical groups just had to sort of kick in and get in line, I think that's not going to work. I think it's got to be 70, 80% on their side, us supporting, maybe on the technological side, maybe with financing, those types of things. Certainly in other parts of the country, though, it's going to be reversed, right? It's going to be 80-20. It's going to be mostly on the plan side, driving, and providers taking advantage of some of the scale that the payers can give.
All right, so as promised, opening it up to you all. There's a roving mic? Yes, there's a roving mic. Phil Donahue style, for anybody who remembers that. Yeah, thank you. Right, that was a little call back there.
Hi, this is Barsam Kasravi. I'm with Anthem, California. Just my thought on personalized medicine was also more on the genetic testing and the genetic, there's a big 60-minute story a couple weeks ago about how there's medications now that can, kind of slice and dice the DNA from all the way from conception, all the way past, all the way to, from cradle to grave. So it's figuring out how we treat patients now with genetic information, where before we would just get their EKGs and labs. Now we have, what medicines work better for them, what tests, what are they at risk for in the next 30 years. So I think that brings a second challenge to personalized medicine.
No doubt, I'll accept that. My husband is a geneticist. There's a lot of ethical reasons that are coming out, and I think our legal system needs to catch up with some of the scientific knowledge that we're gaining. But I do think, as my husband tells me every day, that general practitioners need to get involved and understand genetic testing a lot better than they're doing now. But along the same line, there's a lot of influence from companies trying to make money, making these big arrays and doing unnecessary testing, which leads to a whole nother wormhole to go down financially, insurance-wise, risk-wise, insurability-wise. So I think there are a lot of legal things that need to catch up with the technology that's going on that's still very muddy.
Great points. Totally agree. It's what I meant. I think we all understand that idea of precision medicine, which I think is what you were referencing. And the good news is those of us that have been in healthcare for a decent amount of time understand that it's progressing, right? And we talked about this earlier in my forum. People are living longer. There's new medications. There's new treatments for diseases that either have been around or there's new diseases, in fact, being discovered. And we can do a lot of work upstream. The question and the issue that I think you raise is a good one is there's a reason we don't have MRI bodies or CAT scanners in every hallway that we walk through. It's because what do you do with that? So how we pay for it, how we make decisions that are evidence-based that ultimately affect the right outcomes and the right measures is the key. If it's affecting outcomes, it's affecting costs, if it's affecting quality, we're obviously going to have to do it. How, I don't think we know yet. But again, I think we want to differentiate personalized care in the whole context versus precision medicine.
David Jacobson with Arkansas Blue Cross, and I guess just to build on that, you really commented. What I was going to say is that coming in, when I saw personalized medicine, I thought of genomics and precision medicine, but I think you've opened it up that it's really broader than that. That's one piece of it. And when I heard you talk about it, I'm hearing it's patient-centered, holistic care. So we all talk about person-centered care with evidence-based coverage, but it's also broader, using of broader services with social determinants, and ultimately maybe personalized care is the consumer experience. Talk a lot about the consumers in healthcare, and in the technology world and outside of healthcare, consumer experience is so important. And where that ties into technology, I think that got to be careful not to overuse or get excited about technology. It's an enabling thing, and you got to start at the end with what is the consumer experience that someone wants. It's very individualized, and then what and how can you use technology that's available to get to that point.
Great point. Great point. Yeah, I agree. Any other comments or questions? Yep.
So building, Kevin Lewis, Community Health Options, building on that last comment, consumer experience, and I want to tee this up a little bit because I think in some ways what we're really talking about is the return of the era of personalized care. It's obviously with the technology and the systems that are in place today, it's not my grandfather's era where he went out, did house calls, and got paid with a chicken. There are some endearing aspects of that style of practice. But I think now, with all the technology and tools, we have a much better horizon to look forward to. Yet, the employed model seems in many ways, while it was a natural reaction to regulation, it's a natural reaction to the quote-unquote technology, as you mentioned, Dan, in terms of clunky EHRs that are nothing more than databases that don't work the way they should. So we've lost sight of the well-being and outcomes because of the way that we've organized labor. So to what extent do you think technology today or tomorrow might enable sort of giant slayers of practitioners who could break free of the trappings of the employed model and perhaps with the 3 A's, Alphabet, Amazon, Apple, tackle some of these vexing problems that are systemic as opposed to reaching the kind of outcomes and well-being that we're striving for?
It's such a deep and rich question, so provocative. I mean, can I turn it back to you for your thoughts and your answer, and then maybe expand on it rather than just overtly falling on that sword, because there's a lot to unpack there, I think.
Well, I have lots of thoughts. I don't have any answers.
Yeah, love to hear them.
I see, we had a great session just before this talking about some of the possibilities by way of channel management that is not necessarily business-driven, but outcomes-driven, and really focusing on what do we need to do by way of lowering cost of care and gaining efficiencies. Rahul was talking about a lot of different avenues. So it feels like we're on the cusp of some real paradigm shift, not to overuse that word, but a real change in the way that we can organize, as opposed to the forced alignment of quote-unquote ACOs that have just tons of problems that go along with that baggage.
Yeah, and I don't have an answer. Again, there's a lot to unpack. I think there's a lot of things to think about. Why are physicians in employed models to begin with? Is it by design or is it by default? It kind of feels a little bit like the latter. Is it generational, right? So how do you unpack or how do you reconcile the intrinsic motivation of the current workforce, which may be different than the intrinsic or extrinsic motivation of the workforce of yesteryear, of your grandfather, of my father, who's been practicing medicine almost 50 years, who had the desire to be independent and the desire to own it, and did not necessarily want to clock in at 8, leave at 4, get their paycheck on time, have someone do all the back office work them, and really be more in that employed kind of mindset of a factory worker, which many physicians nowadays want. And I worked at KP. I think the reason it works better at KP is because it's at least in theory an integrated model where you have a health plan and a medical group and a hospital ideally working together, you're elbow to elbow when you're making decisions rather than you are my employee per se. I think technology can enable some of that. Unfortunately, I think it's done the exact opposite. The EMR is a good example. The other thing is, what's the role of the plans in this in terms of keeping physicians independent? Is that in our best interest? I think at Blue Cross of Idaho, we kind of feel like it is. Of course, it's Idaho. It's a very independent state. But the notion of independence, does that breed certain ingenuity? Does that breed certain innovation? Does that align the right incentives where I have to own it more and I have to be responsible and be accountable? And then how do we create shared savings arrangements and risk-based arrangements that facilitate that? So throwing a lot more spaghetti on the wall. And I think there's again, generational issues, technological issues. There is a role, I think, for the payer in that. Because typically the employed model is provider system based, as we all know. How does the payer fit into that in the case of KP? I think that's something we'll see more of as we move forward. Optum obviously is a typical example.
I can add just a little bit to that. So I was thinking about that too, and I think that really varies a lot by geography as well. Like you were pointing out, Dave, I mean, rural areas, different states. Florida does have some large physician groups, so we also have a lot of solo practitioners and really small practices. And so I think the challenge is being able to afford some of the technology that they might need to kind of get into the game. I think what we're seeing is the clinically integrated network has helped that a good bit though, right? Because a lot of the health systems or large physician groups that we work with recognize that they need physicians in the community, and they're virtually connected. And even CMS this year made an effort to think about, how can we have small groups join virtually for macro participation, because it's hard to scale these models and programs with small groups. So they kind of get left by the wayside, or they're not able to fully participate in some of these things or have as much of an impact when they're small, which is a shame because I think there's so many good reasons for them to be small. But it's almost, like to move forward, to sort of move forward with these big programs, they do need some of that connectivity. They do need kind of that governance and structure of a larger organization, but I don't think it has to be an employed structure. It can be an integrated network where you're combining employed and community, which I think we're seeing a lot more of today.
Other comments or questions?
Yusuf Rashid with Community Health Plan of Washington. And 2 quick questions that might end with a period here. First one, I think that there's a place where the precision medicine and personal medicine might actually meet. And I'm thinking of that Leave It to Beaver sort of scenario where I might be talking to my physician and they're talking directly to me. and that's great, but I want them to know me better than I know myself, and even maybe better than that interaction. And that's a place where that EMR might be able to provide data beyond a study from Scandinavia that tells me what I should be taking, but real-world data by people with the same age, ethnicity, the same genomic makeup from the test that I have that might say, oh, give him half a dose because he's not going to be able to sleep. And that's what we know from years of data that the physician doesn't have when they're exercising the personal medicine. So that's where I think there's an opportunity for personal and precision to meet. And secondly, regarding the quality measures, that resonated with me as well, with the place to consider specialty medicine along with primary preventative care measures. If, for instance, I'm diagnosed terminal cancer, 9 months to live, my health plan shouldn't be incentivized to send a letter to take that cholesterol medication next month to avoid the cardiovascular event 10 years from now. But that's how the incentives are set up right now, and it's just, to your point, the quality measures, and I think there's an opportunity to look at specialty medicine, how they might change how we do things there. Thank you.
Yeah, I just love the comment, and I can't believe I'm going to say this out loud because I don't know how you'd possibly put this into practice, but I love the idea of personalized quality. So to what degree does a patient want a certain outcome, and you measure against that, and it would be probably very, very vulnerable to abuse, and I can just see so many reasons why we would never adopt that as a country. But I love the thought behind it, that a physician and a patient should be able to have a conversation, should be able to decide what the right outcome is for that person, which may or may not, for that woman, involve a mammogram screening. Maybe she doesn't want to. Maybe she views herself at low risk. Maybe she's had bilateral implants put in, and she just doesn't want a mammography screening because of the inherent risk of the screening itself, right? So, I mean, I just think, you can just imagine this and where this could go, but I mean, I love the idea of just pushing on quality and using the vehicle of personalized care to do that. I just think you can go to interesting places.
I mean, only one more comment. I really like where you talked about your first piece of integrating back this notion of integration, sort of data and information. And I think one of the values that I have seen, at least in the payer system that I work in, is that ability to not only aggregate data, but to provide information. Clinician systems or clinicians individually and patients to some extent don't have that information. So what's the value add that we can have as payers to aggregate data and to provide information that at that motor endplate really makes it personalized different for the patient? That is one of the values that I think we really have, and one of the opportunities in healthcare, particularly as a payer.
So with just a few minutes left, let me just toss out a statement, and you either can riff on it or choose not to. But I think throughout the discussion, the concept of returning to a more traditional form of medicine and healthcare has come up a lot. This notion of a much more community-oriented physician. I had images of the black tote bag in my head as people were saying this. At the same time, I think we have to keep in mind, right, 20 years ago, To Err Is Human comes out. It became very clear how much harm was occurring in healthcare that was not known to folks. There has also always been and continues to be sort of endemic inequity in the American healthcare system, right? Communities of color, certain immigrant populations, poor folks that just don't have access to the same services that the rest of the population does, that don't have the same outcomes. So I think as we have this traditional notion in our heads, as we think about advancing to a future of personalized medicine, how do we avoid the pitfalls of both the past and some of the pitfalls that frankly still exist today? I toss it out there. Anybody in the room? Reactions, non sequiturs, thoughts about that?
Well, I mean, we're already seeing more and more measurement. Certainly, from the regulator side along this, there's a growing expectation that we on the plan side the payer side are going to be doing more of that measurement ourselves and benchmarking. So I think that is a role for regulators and payers, right? So I mean, we've been talking about kind of who owns what. I think here's a great place where plans and regulators work together, and we have a mutual interest in providing high quality products in the geography we serve in, right? And to some degree free up providers to sort of not have to worry about that surveillance, but partner with us to accept the data as it comes out and work with us to identify and address inequities as they come up. But I think that's a great long-term role for plans.
All right, so we've got a minute 17 is what I can see. I'm going to give the panelists the benefit of the last word. So we'll just go down again and maybe crystallize what's sort of the big picture idea that you felt was most important from the discussion. What's your single take home? You're going to be thinking about it on the plane tomorrow. And now it's a minute flat.
Keeping the patient in the center, listening, being a good listener so that we can adapt all the wonderful, innovative things that we have access to, but while making it a personalized approach.
Awesome. Dan?
Yeah, I mean, medicine is personalized care by its nature. It requires integration between clinicians, patients, systems, be they payer or provider systems.
Don't lose the patience in the measurements.
David, it's 30 seconds, man. Awesome. I love it. So it's really great. Thank you for the conversation. Let's please just thank our panelists for their great thought.